All right, guys, so with that, I'm going to transition into talking about complex venous reconstruction. What results should we expect? So this is going to be a whirlwind of a talk, and I'm going to try to get through as much data as I possibly can to help us sort of guide what to expect when finishing iliofemoral reconstructions. No relevant disclosures. So it's important to keep in mind when analyzing the data that's out there right now that you're really looking at three different types of pathologies mixed into one data set. You're looking at patients that have post-thrombotic disease, which is very different from non-thrombotic venous compressions, which is extremely different from acute DVT. And so that makes it very difficult to tease out meaningful data. And with that, I want to highlight this one sort of article in press that is not yet out yet, but for those that are interested in this topic is available online, which really highlights a lot of the things that we'll be talking about today, which is a position statement from the SIR on chronic iliofemoral venous obstruction, going through data with metallic stents. I want to spend a couple of minutes and we'll talk about this stuff sort of in level of, we begin with the highest quality data that we have and then sort of branch down to different levels of evidence that's available to us. And so this paper, I think, is actually very, very important. It is the only randomized double-blinded trial comparing stenting of venous obstruction to best medical therapy. It's a paper from 2018 from the journal Vascular Surgery, Venous and Lymphatics. And what the study basically did is it took a look at patients with C3 to C6 disease who had been managed with best medical therapy for at least 1 year. These patients had to have a visual analog score of at least 3, and they had to have a VCSS score of at least 10, with IVUS confirmation of at least a 50% area reduction of an iliac vein. And these patients were then randomized to either continued best medical therapy or stenting of the iliac vein. And it's a small single-center study where 26 limbs were randomized to stenting and 25 to best medical therapy alone. And the endpoints were to bring the VAS score to below 3, the VCSS score to below 9, and to see an SF36 score improvement of at least 30. The authors here did a good job technically, because if you look at the stent patency rates, primary patency at 1 year was 92%, primary assisted at 96%, and secondary patency of 100%. And so I'm going to have you guys look here. It's a busy slide. If you look at the stent responders, 92% of patients had met their endpoint in pain reduction versus 8% in the best medical therapy arm. If you look at the SF36 score improvements, 85% met the endpoint versus none in the best medical therapy arm. And so if you look at the data a little bit more, as far as the mean VAS pain score improvement, it was 8 to 2.5 in the stent arm versus just 8 to 7 in best medical therapy. VCSS follows a similar trend, and so does the SF36. So this is very strong data, but again, it's the only such data that we have. Next up comes a set of just systemic reviews, which I'll try to fly through in the interest of time. So the first is a review by Seeger, which is looking at 16 studies, 2,500 patients, stents in 2,700 limbs, looking at both post-thrombotic and non-thrombotic etiologies. Now, for all these systemic reviews, you have to remember, right, these are looking at multiple studies with different endpoints, different stent techniques, different stents used, evolving technique, different beliefs in how to treat patient, different antithrombotic regimens. And so the heterogeneity here is just all over the place, so it's very difficult to extrapolate anything, but yet this is sort of the next best set of data sets that we have available to us. And so these are the different parameters we looked at: chronic venous disease, or they looked at signs and symptoms, ulcer healing, quality of life, stent patency, and complications. Yet the only takeaways really here are that stent patency was anywhere from 32 to 99%. So not really helpful, yet still, again, keep in mind some of the best data that we have. Next comes Razavi's group looking at safety and effectiveness of stent placement for iliofemoral venous outflow obstruction. Also a systemic review looking at 22 studies with nearly 2,300 patients, half and half, PTS and NIVLs. And they try to break things down into non-thrombotic patients, acute thrombotic patients, and chronic post-thrombotic patients. Here are the only sort of takeaway points from these thousands of patients seen. And so in the PTS arm, there was complete relief of pain in nearly 70% of patients, complete relief of edema in nearly 63% of patients, and complete relief of ulcers in nearly 70% of patients whose iliofemoral veins were stented. In the NIVEL populations, the numbers were a little bit better, at 81, 68, and 81% respectively. If you look at primary patency at 1 year for the PTS group, it was in the upper 70s%, in line with all sort of the IDE data that we saw so far, versus 96% for the NIVEL population, and both cohorts did really well when taking secondary patency into account. We now go to yet another systemic review, but this time the authors had enough data to actually perform a meta-analysis on a couple of different variables. This is a study out of the UK, and this looked at specifically the 16 different observational studies looking at dedicated venous stents alone. So this is pooling a lot of the IDE data that we discussed earlier today. 71% of the population was post-thrombotic, and what they did is, this is what they saw. And so in the patients that were stented, ulcer healing was seen in nearly 74%, major bleeding rates were low, minor bleeding rates were low, and there was a 30-day in-stent thrombosis rate of about 8.5%. You can see sort of primary, secondary, and primary assisted patency curves, which are similar. 70% range in the mid-70s, primary patency for the post-thrombotic lesions, and the upper 90% range for the NIVEL lesions, again in line with everything that we saw. And as discussed, 8.5% of patients had in-stent thrombosis, and 5% actually had incident of stent damage. We now move on to another systemic review looking at venous stents for the iliac and veno-caval, and this time also veno-caval occlusive disease. Systemic review, 23 studies, nearly 4,000 limbs. Some of these patients had dedicated venous stents, some had standard stents. Of note, the landmark Neglin study was in this. It's actually in all these reviews, but a large portion of these patients with standard stents were from that landmark study in all these reviews. And this is our takeaway. So patients that used standard stents, not venous stents, these are the sort of outcomes to be expected at 24 months. Nearly 80% had symptomatic improvement, nearly 70% had ulcer improvement, primary patency rates again in that 70% range, secondary patency rates again in that 90% range. And as far as venous stents are concerned, the only takeaway here was what we've seen in the IDE trials, which is primary patency in the in the 70s range for PTS and upper 90s for NIVEL. Sort of all repetitive themes here. Last but not least, we have sort of the largest systemic review and meta-analysis looking at iliofemoral obstruction with both dedicated and non-dedicated venous stents. This is nearly 50 studies looking at 5,000 patients, all types of patients, NIVELs, acute DVT, and PTS. And yet again, we see the technical success was excellent in all cohorts. Primary patency at 1 year for acute DVT, 90, for NIVEL, 96%, for PTS, again, in that 70s range. A real interesting takeaway here I saw is they were actually able to stratify the patients with PTS who were stented with above and below inguinal ligament stenting to find that there was no difference in outcomes, which I thought was a nice takeaway. As far as venous claudication is concerned, an overwhelming majority of patients did well and responded. Ulcer healing, most PTS patients responded. NIVELs not so much, which isn't surprising because most of the times NIVELs should not be causing venous ulceration. And so, just some thoughts, right? I know that's a lot of information and a lot of just sort of a whirlwind, but the bottom line is venous stent technology has come a long way and it continues to evolve. And there is a wealth of observational data showing us the same stuff over and over again, which is there's great stent patency, they're fairly durable out to 3 years, the NIVEL patients do really well, the PTS patients tend to be in the 70% patency range, 70 to 80% at 1 year. Our technical expertise continues to evolve. Our tools continue to evolve with IVUS, sharp recanalization tools. And the data we have certainly highlights how crucial it is, how crucial a role endovascular intervention plays in patients with moderate or severe chronic deep venous disease. There's no doubt about that. Yet, here we are today, and it's really difficult to extrapolate anything meaningful when comparing endovascular intervention to best medical therapy alone. Just one real paper still. And I remember talking about this paper 5 years ago, and 5 years later, it's the only one that I can still really get excited about. And that's really goes to highlight where we are and how much work there is to be done. And so, with that in mind, I can only hope that, we enroll patients into C-Track and we get the answers to a lot of our questions, really comparing stenting, chronic deep venous occlusion or obstruction, and comparing that to best medical therapy. Thanks, you guys.